28-year-old male presents with right ankle pain and swelling after inverting the ankle during a run 2 days ago. Unable to bear weight for 4 steps. On exam, there's tenderness over lateral mal. No tenderness in the medial mal or the fifth metatarsal. No significant swelling and bruising around the ankle. Or there is significant swelling and bruising around the ankle. What is the most appropriate next step in the management of this patient? Yeah, what do we like? What am I asking here? Yeah, Ottawa criteria, right? So which criteria does it meet? What's that? Yep, and what else?
Inability to bear weight.
Yeah, he's unable to bear weight. So what are all the criteria?
Inability to bear weight, malleolus, tenderness, navicular tenderness.
Yeah, so inability to bear weight, lateral medial mal, posterior lateral medial mal tenderness, tenderness at the fifth metatarsal, and then tenderness over the navicular are positives. Good. Man, you guys got this. All right, let's do another one. We got a 49-year-old female presents to the clinic with great toe pain that worsens with physical activity. She's a former collegiate athlete who remains physically active with regular aerobic exercise. On physical exam, there's mild swelling in the first MTP joint with significant pain and limited extension, flexion, and range of motion at the DIP joint are preserved, which the following is the most likely diagnosis. What are we thinking here? What do we got?
Limited extension means rigidus.
What's that?
Limited extension means rigidus.
Yes. Hallux rigidus. Good. Good. So, what else we got with the, what else did we talk about yesterday with the first MTP of great toe? Kind of like read my mind, you know. What's that? Yeah, we got hallux valgus, we've got turf toe, and then if it was on the plantar aspect, it would be like a sesamoiditis. Good. Let's see what else. I think I got another one. All right, 61-year-old female presents to the primary care clinic with pain over the medial aspect of her foot. Physical exam, there's prominence of the medial aspect of the first MTP and lateral deviation of the great toe. Foreign is present over the medial prominence, which is the following is most appropriate initial treatment for this patient's condition. Yeah, and pretty much all the foot complaints just about. Yeah, so this one, roomy toe box. So what is this? Yeah, it's hallux valgus, also called the bunion. If it was a bunion net, it'd be the same treatment, wider toe box. Good. Everybody good with that? Understand? All right, let's talk about some ped stuff. Are y'all good with the mood lighting? Fine. Okay, cool. All right, so here's a little roadmap today. We'll talk about some of the pediatric complaints that are more common. So that'll be your os trigonum, accessory navicular, Sever's disease, which is calcaneal apophysitis, cavus foot deformity, and then club foot. All right, let's move into the os trigonum. So this is basically an accessory ossicle. Look at the posterior talus. So it's a normal variant. We see it, not infrequently. It becomes an issue, especially with anybody that has like extreme plantar flexion. So, they say ballet dancers. I don't know that has anybody do ballet? I don't think I've ever met a ballet dancer in my life. but apparently they're out there. So it's really anything that causes that extreme plantar flexion. So it's like soccer when you're, after you kick the ball can cause this extreme plantar flexion. So that's when you'll commonly see somebody complaining of this. Normally it's not noticed, but it causes like bony impingement on that posterior ankle. Usually activity related or, related to that extreme plantar flexion is what the patient's going to be complaining of. So, what do we do for these ones? We're going to get that AP and lateral foot x-ray. I think like a good rule of thumb for most complaints, because we always talk about we want weight bearing versus non-weight bearing. So anything more acute, we usually want like a non-weight bearing. Anything that's more chronic, hopefully that's an easy way to separate it in real life. I don't I don't know about on the test, but no, most of the time, like chronic complaints, we get the weight bearing. So yeah, you guys can see that positive arrow sign on there. They have that accessory navicular. On your exam, you want to make sure you're differentiating whether you think it's like some sort of Achilles tendinopathy is another thing that can present with similar symptoms for these. And then if it was, let's say it's like an Achilles problem, so on this patient, they're gonna have that pain like with extreme plantar flexion. Would I expect that pain with an Achilles issue? So these are like ways to think about it. So if it's Achilles and you're doing that plantar flexion, you're not tightening the Achilles tendon, you're actually you're relaxing it more. So with an Achilles tendinopathy, they shouldn't have pain with it versus this. With extreme plantar flexion, you're going to dorsiflexion is when you should have pain with like the Achilles tendinopathy because you're lengthening that tendon. So they're like, nice little differentiators you can think about there. For this, we can try non-operative treatment with most things. We're going to start with that. So and some anti-inflammatories. Does anybody have like a preference on anti-inflammatories? What do y'all like to give? Motrin? You guys just like Motrin and water. Yeah. In practice, I like naproxen because it's one pill twice a day, maybe a little easier to take. But sometimes people need a placebo effect to take it multiple times a day. So some Motrin can be nice if you're taking it every 8 hours or whatever. But we're going to do our rice therapy for activity modification. Sometimes you can immobilize it for this as well. And then anybody that fails non-op treatment, we look at sending them to surgery for refractory cases. Normally, at least 3 to 6 months of therapy first is what we recommend, non-op treatment, and then if they fail that, then we look at sending them to orthopedics or putting a referral in for orthopedics. All right, next one's going to be our accessory navicular. So pretty common, like 14% of the population can have this accessory navicular. And it's kind of like how basically you have a secondary center ossification, but it's kind of like almost like a sesamoid is, right? But you're not supposed to have it there. So it's basically attached to that posterior tibialis tendon, and it becomes symptomatic, especially when they start to have more activity. You'll also see this asymptomatically. A lot of patients will present and say, what is this bump on the inside of my foot? And that's usually what this is going to be. And it'll make sense in a second with some pictures that we show you. But I've definitely seen it, just not symptomatically. Usually it's a question after somebody rolls an ankle like, hey, what is this bump I've always had here? And then we tell them what it is. So what do they present with? So that, most patients are going to present with some sort of pain. So you may see swelling and foot pain. You have a medial arch. Usually it's more atraumatic when they present. Certain shoes are going to cause irritation in this area, which makes sense because it's kind of close to the inside of that arch. So depending on what type of footwear they have on, they'll be more symptomatic or less symptomatic with it. If it's irritated, they will have tenderness over that area. As they mature more, you'll see sometimes see that bump that you see on that picture there. And then they also might have, a flat foot with it as well, or a flexible flat foot, which we'll talk about here shortly. All right, so there's our films for these. So this one, like an AP is the best view we can get for it. You can kind of see that accessory ossicle or a bone that shouldn't be there on this patient. You don't need it for the diagnosis, but if they're having like persistent or chronic symptoms and and you want to get an X-ray, you can get a weight-bearing film to assess these. And like I said, like more chronic problems, weight-bearing is usually a great option for us. once again, I feel like a broken record. So we're gonna start with non-op treatment. So anti-inflammatories, rice, activity modification. You know, we recommend shoes that don't put any pressure on that area, or we can use like shoe modifications. I've seen people put like a donut on there sometimes. There are certain pads that we can place over it. If it's more chronic, we look at doing like we look at doing casting for those micro fractures on it. And then surgery may be necessary if it's disabling, so they're like having difficulty walking or issues with that. We usually put a short leg cast if we're casting them. And then for surgery, they can look at doing an excision, which is called the Kidner procedure. So that's like a classic like PAMS question about, you know, if they failed non-operative treatment, what's the procedure that we use for it? And it's the Kidner procedure. This is calcaneal popsitis, also called Sever disease. These are usually active prepubertal children. And this is really like pain on that posterior aspect of the heel is what they normally present with. And it'll have usually some sort of traction on it. We see like an Achilles tendinopathy with these, because the Achilles tendon kind of pulls on that back portion, and then that bone is not the growth plate is still open, so it creates inflammation of that growth plate. It usually resolves once they start to hit puberty. So the key for this is we never do surgery on it. Is the big like board question type picture if somebody is in that age group. So these questions, always pay attention to the age when you're looking at them, and in real life with the patient as well. But this is going to be mostly self-limiting, activity symptoms. So that when they're exercising or in gym class, a lot of times, or the teacher makes us run laps, I start to get this posterior heel pain, and it's different from like a plantar fasciitis, because plantar fasciitis is more on the plantar aspect of the heel. This is going to be more on the posterior aspect of the calcaneus on physical exam and when they're complaining of as well. One of the tests we do is just like a calcaneal squeeze test and just doing medial and lateral compression on that heel. And that should reproduce their symptoms. That's like the classic finding you see with it, we call it the calcaneal squeeze test. And then x-rays are not super helpful in these because you're going to just still see an open growth plate there. So the bones have not matured yet. So it's kind of hard to really diagnose anything with the x-ray on here. If you're worried about a bone cyst, that's something you can x-ray for, but these really aren't useful in the diagnosis. And then for treatment, it's going to be all non-operative treatment. Surgery is never indicated. And that's like a common PANS question, like, what are you going to do for this, 8 or 9-year-old, 10-year-old with posterior heel pain, and it's, never surgery. It's going to be conservative management. So NSAIDs, rice, activity modification. We can give a heel lift in there to help out with it, and it provides a little bit more cushion. We also want to look at that Achilles, because a lot of the times they'll have a tight Achilles because their gait will have changed with this. So we want to make sure we're providing them good Achilles tendon stretching, like a home exercise program, and assess that when they're in there. Rarely they can cast it for 4 to 6 weeks. And that's really for somebody who's like severely limping. Our next one's going to be our cavus foot deformities. So there's going to be like the high arch patient, and that's pretty significant arch on that picture there. So here's a great example on it, and then we kind of assess these. The patient may or may not present with symptoms with it. This may be noticed incidentally on exam, and especially that like bottom picture. Have you guys ever maybe you're not judgy yet, but once you're providers, you'll walk around and like see people like, oh, they got something wrong there. They can get that checked out. So when we look at these, we try to assess like where the movement is in it. So we have cavo varus, which is like more of an equinus with a hindfoot varus. So we just kind of look at how they're walking. So like the it'll make sense when we look at the like worse condition, like clubfoot and things like that. But the key for this one is we need to make sure we rule out some sort of neurologic or neuromuscular disorder, especially if it's unilateral, so they can have like cord tethering. So for these ones, you know, this is something we want to consider, like spine x-rays as well, looking for any sort of other conditions, scoliosis, things like that. But usually they present with like, you know, shoe wear problems. So one shoe's going to be a lot more worn than the other if it's unilateral. They're going to, you know, because of the way their gait has changed, you know, they're putting more pressure on those metatarsal heads, so they may come in complaining of that. You know, it could lead to plantar fasciitis or fascia pain. Most of them will have frequent like inversion ankle injuries, which hopefully makes sense looking at kind of how their gait would be on there. They're not able to ambulate like normal, so they're going to chronically roll that ankle. Maybe another complaint you see with it. Could be some calluses on there as well. You may see a family history of it, and that's especially important if we're looking for some of those like congenital diseases, but we need to make sure we're doing a good neurologic assessment on these patients, and then we're going to get an x-ray for them. So this is going to be weight-bearing AP and lateral, and then we're going to look at a Miri angle on there. So, you know, it's supposed to be 0, or the typical angle is supposed to be 0, and then if there's any increase in that angle, it's usually pathognomonic for this. And then if we see it, we want to get that thoracolumbar film and assess it for scoliosis or any other conditions that can cause like cord tethering or neuromuscular disease. We may see it in. So our treatment is based on underlying disorder for this, so we want to make sure we rule out any of those other neurologic causes first or congenital causes in these patients. And then we assess it on whether we think it's those deformities are going to be flexible versus more rigid. So like, can we passively put their foot into a normal position versus whether it's like that permanently, and that's when we would kind of base on whether they're going to need operation versus non-operative treatment. But most are going to get some sort of operation on it. So they may have to do something simple like just soft tissue releases versus tendon transfers and osteotomies, where they have to remove some of the bone and realign everything for it to work appropriately. If they have an underlying disorder, then it's likely going to be a recurrent issue for these patients, which is why we want to identify those and treat them appropriately, or else we're never going to fix this problem. And then we have our club foot. So this is something, you know, we usually find when they're in infancy, and something we assess for on those patients after, you know, during their like well child checkups. But it's, according to the data, it's one of the most tested pediatric orthopedic conditions on the pants. So this is going to be, you know, you can have a congenital club foot versus like Felipe's equinovarus. It's characterized by 4 components. So you kind of see in the picture there. So they have a high arch or midfoot cavus, and then they have forefoot adduction. And then the heel or the calcaneus will be an adduction, and then you'll have equinus, which is plantar flexion of the foot. And then we want to look at whether it's flexible, so can we passively put that into its normal range of motion versus like an idiopathic and we can't fully correct it. These are another thing we want to consider, or any other disease or any other pathology that would be associated with an underlying disorder with it. But most of these are going to be treated, you know, if we treat them appropriately, we should find it in in their infancy, and that's when we're gonna have the best outcomes for these. So, obviously they're not gonna be symptomatic, because we notice it at birth. And I think nowadays, you're not gonna see this a lot in the US unless you're in, working on, like a labor and delivery or a PICU or one of those places where you're gonna see them immediately after they're born. But if they end up, I would find it hard to believe to see in this country, but if they end up ambulatory and it hasn't been caught by then, they're gonna complain of like some gait disturbance. They won't find shoes that work appropriately, they'll have some pain. But what's important for our physical exam is ruling out any of those other neurovascular disorders in these patients. We want to evaluate for any sort of spine abnormalities. And then we can use instead of imaging on these patients, there are some other options we can use. If we don't like to image babies too often, but if they present as children or older and ambulatory, then we do the weight bearing AP and lateral foot radiographs. I don't know how somebody would have walked around like that with club foot and adult. Nowadays, especially in the United States, but it probably happens somewhere. But it's obviously gonna have pretty significant adverse outcomes. So they're gonna have, some sort of disability, impaired walking. They may be using a cane a lot of the times if they're older. And then they're gonna have difficulty finding shoes on there. They can get those custom the boots like you see on the bottom for a club foot. I was looking at it, I was like, man, those things look like 100 years old, and I looked up newer versions of them, they still don't look much better than that. A little bit better. They look like some amped up Doc Martin looking things, but yeah, not much improvement on it. That's probably because we fixed most of it at birth. But our treatment of choice for this is gonna be the Ponseti method, so that's serial long leg casting, preferably in their infancy. And then we look at doing like an Achilles release, so it's like little micro needling is kind of how we do an Achilles release on these. And then after casting, they will wear a brace normally for the first 3 months to a few years. It does have a high recurrence rate. And then if they're older or persistent recurrent symptoms, we look at doing operative management on these patients. Man. I don't know how to drag it out to 2 hours for a lecture. There's 20-some slides, I'm like, I don't know what I'm gonna say up here for 2 hours. So, yeah, there's what we covered. So, big things on here, just looking at classic vignettes, because a lot of these are going to be classic vignettes, especially on the pants and on your testing. So, adolescent ballet dancer with posterior ankle pain. You want to think about os trigonum. If it's like a 14-year-old with, medial foot pain and a bump on there, pain with inversion, then we want to x-ray and look for that accessory navicular. If they're pre-pubertal and they're complaining of that heel pain, we want to think about Sever's disease, and we don't want to do surgery on those. And I guess if somebody made it to 10 years old with high arches, claw toes, and a bilateral foot deformity, we want to think about other neurologic conditions that can cause this, like Charcot-Marie-Tooth. For an 8-year-old, if you have a unilateral cavus foot deformity, then you want to think about spinal cord tethering, and you can look at either plain films for scoliosis, sometimes MRI, but we don't. That's beyond our scope normally. And then if you get that newborn with all four, high arch adducted forefoot, varicose and plantar flexed ankle, we want to look at, our treatment choice is going to be that Ponseti serial casting and considering a Achilles tendon release on them. What questions y'all got? All right, take a 10-minute break and we're moving to the next lecture.
No, yeah, from the brand. Oh, you like seatbelts.
Because they put it in.
Call me. See who it is.
What's up?
Yep. So maybe it's the. Yeah, maybe it's that. Maybe they're pulling it down. Isn't that what we got for the ball? What's another difference here?
Should be like similar bump.
Yeah, I get the line goes straight to right. Yeah, that's traffic down. They want to speed out. Whatever.
Well,
Yeah,
you
like,
could
yeah,
if it were.
wait, okay, they're pulled it. Yeah, so like,
What's that?
a lot of businesses,
Yeah.
they'll want
Probably have to
their
serve
phones
gas.
on internet, so if the internet goes down, then remember when I was the vet officer before, we had extended our price until when the internet went out, so there's a problem. Even though they should be two separate things.
No. What time did you say tomorrow again? I'll say if, like, I could do 8 tomorrow.
But it's no worries. Actually, makes us first period, whatever y'all want to do, but whatever.
I call the house. Not bad. And the other thing too, doing it with a spouse. Because like all the things I would do someone that's not doing it. And so when I got here, I was like, hey, I'll move it. You need to tell me. No, I don't want to. So I went and did it. All the things you tell me what she is.
Next week, no. So, 2 weeks, over the next 2 weeks. Now I free up, so if they still have it, or they just cancel it.
Yeah.
All these are just your-
Yeah, I was talking about
Yeah.
Yeah, you could put, Hero's already there, so just. What card, I don't know what card you'll buy.
It could be
Literally, all the way. We were all just pretty cool. So, good luck. Well, 20 minutes and we used to in front of them. I'm ready to get the ads like still pay the jump.
He's like, I still got me myself, headset.
No, he's like, I'm still down.
I feel like, you should download this on your phone. So you could like. Turn up.
You gotta have your priorities.
What is practice? You go past the you go right there. You gotta figure out what the fuck you're doing.
Alright, you gonna keep pushing? You're probably stuck here all day anyway, so you don't care. You guys should enjoy the semi-normal temperature you have in here for the next month. Because the senior classroom's like 60 degrees. Freezing. Terrible. Alright, let's continue on with our ankle and foot pediatrics. Here's our roadmap. So we'll talk about flat foot, metatarsus adductus, osteochondral lesions of the talus, and then tarsal coalition and toe locking. All right, we'll start off with the flat foot. So this one's going to be, anybody with a normally low arch. Sometimes they may not present complaining of pain, especially kids are pretty resilient. But anybody with that like low arch, we also see a lot of adults too. Usually can be more of like something that developed over time, like we talked about in the first or second lecture with that like posterior tibial tendon dysfunction. But most of these patients, it's a normal variant. The arch doesn't develop till they start to mature more. I don't know if I'd say mature at 4 years old, but they're not a baby anymore. So normally, we'll start to see it, between that 4 to 10 year time frame. So that's another like important thing to remember for when you're differentiating these on the pants or when you're test taking. What do we commonly see in certain ages? It's important to always think about that. Which I know is not fun because you're like, man, it's like all different ones with all kinds of ages on there. Just wait till Pete's next semester. That'll be even better. But most common is going to be a flexible flat foot, which is better because usually they're asymptomatic, especially in kids. They don't really complain a lot. Rigid is going to be less common, and that's when we once again worry about some sort of congenital abnormality, neuromuscular diseases, and things like that. And we see it in obesity, which hopefully makes sense. Got all that extra weight on there. I think that the obesity rate for kids is pretty high nowadays too, unfortunately. But if they're standing, like sometimes you can, if you're unsure on your exam when you're just looking, you can have them get their foot wet and they just step on like a paper towel or something and you can kind of see where their arch is. So that's kind of how the example is on the bottom. All right, so the one thing we want to differentiate on these patients, whether it's flexible versus rigid. Maybe something incidentally noted on an exam that they have flat feet, which is fine. Usually with a flexible, they'll be asymptomatic and it's just incidentally noted. Once they start their school, they may notice it more with running activities or gym class. They might have a little bit more difficult time keeping up. So that's something to think about. And then they may become symptomatic if we have that like Achilles contracture or other abnormalities associated with it. But on a physical exam, like what's important is, when they're weight bearing, they're gonna have that loss of arch, so they'll have flat foot. But if they're non-weight bearing and you notice that they have a return of that arch, that's gonna be our flexible flat foot, and that's like a key differentiator to pay attention to on these. So, if they're standing up, they get a loss of arch, they may have that like valgus alignment on there. Does everybody remember the like valgus versus varus? Hopefully, I always remember one's like kind of shaped like an L out, the other one's more shaped like an R boat, or another easy way is like for valgus, we a lot of times think the lateral side it's hit, or versus varus would be medial. And then we also have like our extension of the great toe is called the jack test. So if we can recreate the arch with the jack test, that's another indicator of like a flexible flat foot versus a rigid flat foot. So it's something we want to think about, especially if we're passively extending that great toe when we see that arch return, and then we would consider it a flexible flat foot. All right, what do we do for these? If it's flexible, once again, most we do non-operative treatment, and the majority are flexible. If they're symptomatic, they'll present. If not, we may just incidentally notice it. But we do the same treatment like we always do our NSAIDs, RICE, activity modification, physical therapy. Shoe inserts can be helpful for these patients as well. And then for operative, rarely for a flexible, maybe if they've failed everything for years, but on our level, we're not really recommending it for surgery. If it's rigid, that's when we want to rule out those other causes. like neuromuscular disorders or some of those congenital abnormalities. And we refer them to ortho. Ortho can do, the procedure on there where they cut, they remove a portion of that calcaneus to help treat this. All right, next we have our metatarsus abductus. So this is going to be, that the metatarsals are medially deviated. Typically we see it when they're younger. It's the most common congenital foot deformity. So it is something to always consider. And it's the classic cases usually, caused from like an intrauterine positioning during pregnancy. And they are born with this. It's like 13% of, there it is, 13% of full-term infants have this. So you'll see that medial deviation of the forefoot. Most of them are to resolve spontaneously, so we don't really do anything for them other than just kind of monitor the progress of it. I think we got some grading criteria on there. Once again, we want to, it can be associated with other like neuromuscular disorders like torticollis. And then they can have hip dysplasias and other conditions associated with it. All right, so here's kind of our grading criteria. So on physical exams, it's usually we notice it in infancy. You'll see that like abduction of the forefoot compared to the posterior hind foot. And then we want to, like you see they call it wandering great toe in that bottom picture, which you'll definitely see that, especially if you're seeing like well child checks in their infancy. But how we grade this is what's important to remember. So we have our different lines on there. It should, that our heel bisector line should ideally be between the second and third toe on there. So that's going to be our normal. And then as we start to deviate, we have mild. So it's going to be kind of bisecting that third toe. And then moderate is going to be between the third and fourth toe, and then severe is going to be between the fourth and fifth toe. So it's important to know those. And other things we consider with it on whether it's flexible. So can we passively correct that past midline? If we can, then there's like pretty high probability that we don't need to do anything for that and that it'll resolve on its own. So usually we just kind of reassure the parents that it's going to eventually correct. And then like if it becomes, moderate where we can, correct it to midline only, sometimes we'll recommend stretching exercises for it versus if it's like rigid, then it can't be corrected past midline, so then we would do casting in those cases, very rarely surgery. But we want to assess flexibility first. So once again, we don't like to image kids, especially babies, so and you guys will learn that a lot more next semester. The pediatricians don't like it when we're, irradiating all these children. I still do an ER though, because it's indicated, in my opinion. Sometimes they'll question why I ordered a CT on a kid, but it happens. So, we don't really need a plain film. A lot of times we just do a photocopy the feet and we kind of track it and track the progress through time. So it's very, low cost, it's cheap, it doesn't expose them to any radiation, so you can kind of see the picture there. All right, so like I kind of said, flexible, we just reassure the parent, they're likely going to grow out of this. Versus rigid, we want to look at doing casting on those ones. So usually, the sooner we get them casted, the better, the earlier in life before anything starts to mature. If they fail that, or they have like, residual symptoms past that 3 to 6 month duration, then we want to refer them to orthopedics. Or if it's rigid, those ones we want to refer as well. All right, osteochondral lesions of the talus. So this is, did you guys cover osteochondral lesions? Like a foreign, it's basically like a loose body in the joint. So These are like, you'll get some sort of osteochondral lesions in there, which is typically on the weight-bearing portion of the talus, and it's typically caused by trauma. So usually the patient will have some sort of, inversion or injury prior to this, or chronic ankle injuries, and then it results in like collapse of that surface, delamination of that cartilage, and you get a loose fragment in there. So they're usually complete mechanical symptoms, occasionally giving way. I feel like I got a loose body in one of my ankles, honestly. Like I feel something stuck in there sometimes, and I can't like move it every once in a while. With trauma, it could be an acute onset, but normally we see these more chronically. And a lot of times we'll say it's just chronic ankle sprains, or maybe they never rehabbed a prior ankle injury appropriately. But it is something we want to consider on there. There's our two special tests we do. I haven't looked at the physical exam lab yet, but there's a lab on there, and I was like, foot and ankle, there's like 3 tests we do. We like squeeze the syndesmosis, we do anterior drawer, talar tilt, and the Thompson test. I was like, I don't know. Luckily, the ortho guys are going to come help out at the lab. Maybe they'll have a better idea. But those are the most common tests. There's anterior drawer, you're just looking for any laxity in that joint. You're kind of pulling on it while you're stabilizing the ankle. And then you have your talar tilt, where you're just like he's doing in there. You're just tilting the foot and assessing for mobility in that joint. Patients are going to have, sometimes, especially if it's more acute onset, this will be limited, or they'll have a painful range of motion. You may see diffusion, joint line pain. Things to consider for this, like normally during a like ankle exam, we'll have tenderness over all those ligaments we were talking about. So this one would be a patient that doesn't have those tenderness over like your ATFL and your CFL ligaments during your testing. So that can help kind of differentiate it from other ones. And this one will usually have joint line tenderness, most commonly along that lateral joint line. So that's something else to consider when you're trying to differentiate whether this is like an osteochondral defect versus like an acute ankle sprain. And then plain films, are going to be what we start with on here. So you can, when we get one, we want to assess that mortise, which, is that the x-ray that's on there. So you're looking at the joint space on each side here, and then you look at the joint space, in between the bone superiorly, and you want to assess whether those are all even and equal. And then you can see like that small wafer-shaped lesion like you have on there. So that's going to be an osteochondral defect. And sometimes our lesion, and sometimes they can, dislodge from where they are and get kind of stuck in that joint area and cause more symptoms with it. And then for these patients, if they have a lesion that's symptomatic, we've gotten plain films and they fail like non-op treatment, like MRI is the gold standard test for defining that cartilage disruption and subchondral avascularity. Mostly it's something we would refer to orthopedics for first from our level, and then they would look at doing an MRI on this. So if they're, if they're still skeletally immature, so if they're younger, the age is the key factor on what we do for this. So like children and adolescents with open growth plates still, these are ones that have the capacity to heal, and so we'll look at doing like a mobilization for those. Anybody older or they're reached skeletal maturity, then we're going to look at doing operative repair and taking care of that loose body or taking the chip that's on there out. All right, tarsal coalition. So this is basically, you have some, they call it coalition, or two bones are basically attached together here in the foot, and it's, pretty common, not super common, but it is something that we see not infrequently in practice. So important things on here, if it's it's bilateral 50%, So if we're having to usually get, bilateral plain films on them, especially if it's asymptomatic, we can check that if they have it bilaterally. But really, it starts as cartilage, and then eventually it becomes fibrous and ossifies to that other bone. We see it more like late childhood or adolescence, so once that cartilage starts to ossify in that area, they start complaining of pain. Typically, we see it two different presentations. So like the younger 9 to 13, we'll see a calcaneonavicular coalition. That's just talking about the two bones that it's connected to. And then when they're a little bit older or more teenage years, you'll see like a talocalcaneal coalition, and they'll become symptomatic. So those are like two differentiated key time frames you want to think about for these tarsal coalition. Patients will likely have some limited mobility in there, so they'll complain of like frequent or chronic ankle sprains. They may have a limp. And then on physical exam, we'll have a more rigid lap foot, and then that hind foot motion will be decreased. So when you're asking them to invert, evert on their range of motion, and you'll also notice it on physical exam when you're doing the Taylor tilt test as well. All right. So plain films are, can be helpful for this, and that's usually what we're going to start with. So, if we diagnose this or see it on plain films, great. Sometimes they can get like a Harris heel view, which a lot of these views, you have to really refer them to orthopedics for. I've tried to order some crazy views for ortho. They're not in the system, the rad tech's like, I don't know what you're talking about. So normally ortho most of them have to be done by ortho, ordered by ortho, because they actually know how to perform those certain views. But for this one, and it hopefully makes sense. Like, you guys know why we order CT versus MRI? Hopefully, maybe.
Tissue versus.
Yeah, one looks at like MRI gives you a better imaging study of soft tissue. CT does a great job looking at bones. So a lot of times ortho, likes to do CTs if they're worried about some sort of bony issues versus like an MRI when they're worried about tendons and ligaments and other structures in there that isn't the bone. Like, that's why we get, like MRIs for our knees, because it'll better evaluate the meniscus and our tendons and everything. So treatment for these, if they're asymptomatic, we can observe activity modification. Severe, we look at doing a short leg walking cast for these patients for 4 to 6 weeks. And then if they feel that, operative intervention is going to be indicated, so they'll do a resection of the coalition. And then they may have to, if it's larger coalitions, they may have to do a fusion or an arthrodesis for those patients. Toe walking. I feel like all toddlers walk on their toes initially, right? Does it seem like that? Yeah. All right, so for toe walking, most of them are idiopathic, but it's something we want to consider. Parents will come to you talking about how their kid walks kind of funny and on their toes. If they're, most of them are idiopathic, so if they're otherwise healthy and they don't have any other associated like neurologic conditions with it or a normal neuro exam, this is kind of how we look at that for idiopathic, and they normally grow out of this. If it's persistent and the child doesn't grow out of it, then we need to look for some sort of underlying disease process. The ones we might see with like cerebral palsy, muscular dystrophy, things like that. I had a soldier he was one of my medics that like toe walked. He was probably like late 20s. It was kind of odd, but he did it 24/7. I was like, man, I don't know how you do it. If it's unilateral, then we consider that pathologic until proven otherwise, and it always requires a workup. Most of them are not going to come in for pain, so it's usually just a parent concern that their kid is walking funny. If they are symptomatic, it's usually related to those metatarsal heads and they're walking on their toes. So they have like increased impact in that area and cause some inflammation. So, if we think about how the Achilles tendon and what position, what range of motion it's contracted in, like this one can sometimes have an Achilles contracture associated with it. But when we look at this, we want to rule out those pathologic causes. So it's, what we call a diagnosis of exclusion for these ones. And the big things we just ask about birth history, how's their development been? Which is something I still ask, patients in the ER all the time, especially if they're still in their infancy. And we want to know, is there a family history of this as well? Do they have, cerebral palsy? Sometimes they'll be, I've had patients diagnosed, they don't look like a cerebral palsy. I can't remember the name for basically like any symptomatic cerebral palsy, but they have some sort of gene in there. So it is something to consider. And then during our exam, we want to assess that range of motion, make sure there's no Achilles tendon contracture that we need to treat for these. And then if they're just beginning to walk, it is something that we usually just want to observe. So if they just started walking, they're walking on their toes, that's normal. We usually just tell the parents if it continues, if they're still toe walking for over 3 to 6 months from now, then I would come back in here. We like to give them stretches and a home exercise program if there's an Achilles contracture associated with it. And then we can do serial short leg casting for these patients as well. Once again, I was telling somebody up here earlier, it's impossible to get kids to do anything or follow any sort of treatment plan. So I couldn't imagine placing a toddler in 2 short leg casts and see how that works out. But have you guys ever seen like a kid in a cast and they're like jogging or running biplane and you're like, I don't know if they're supposed to do that. It's very hard to make kids do things. So sometimes you will have failure with some of these therapies. And they have these other kind of braces you may be able to prescribe for them on there. That's usually something Ortho does for them. I don't know. It just made me think of it. What was wrong with Forrest Gump? His was scoliosis, okay. Just made me think of it with his little contraptions there. All right. So we want to refer them for anybody with abnormal physical exams. So you got any neuro findings on your physical exams. Or if we've rehabbed them, they failed out non-op, 3 to 6 months of therapy and it continues, we look at referring those. I would not imagine Ortho doing any sort of heel cord lengthening or surgeries for these, but it is something I would refer to them just so they can evaluate and then consider those other developmental abnormalities like autism on these patients as well. Holy cow, that was fast. Well, hopefully you guys don't think I'm shortchanging you or anything. It'll get longer because the next ones are fractures, and that's what I do all day. Just deal with fractures in the ER. So hopefully it'll get a little bit better. But things key differentiators to remember on here. So flat foot, if it's flexible, so if they're non-weight bearing, that arch is present, or you do that jack test. That's just reassurance for those patients. If it's rigid, we want to investigate a little bit more and then possibly surgery. Metatarsal adductus is most common. Congenital foot deformity, usually from uterine positioning. If it's flexible, then we just reassure. If it's rigid, then early casting. Consider other developmental causes like torticollis and other things that go with it. Osteochondral lesions in the talus. That's, we have those different age time frames that's the next one. This one's, they'll complain of chronic ankle pain, and you'll usually misdiagnose as an ankle sprain multiple times. So if we have any joint line tenderness, we do normal ligament testing with our anterior drawer and our talar tilt, then we want to consider an osteochondral lesion. And the tarsal coalition, that's 9 to 13 years old, think of the tarsocalcaneal. For these ones, a CT is better than an MRI, so that's something we always want to think about. Then if they're you know, 13 to 16, we want to look at like a tarsal calcaneus coalition. And then for toe walking, you know, we want to rule out cerebral palsy, autism, and those other developmental disorders. And then that's a diagnosis of exclusion, evaluate for like, you know, Achilles contracture. What questions y'all got?